Good afternoon, ladies and gentlemen, and welcome to today's webinar. I would like to remind you that this conference is being recorded. At this time, all participants are in a listen-only mode. For those connected by telephone requiring operator assistance during the call, please press *0. Web participants requiring support should use the chat feature on your screen. I would now like to turn the meeting over to your moderator for today, Mr. Stephen Samus, Vice President of Programs at the Canadian Foundation for Healthcare Improvement. Please go ahead, Mr. Samus.
Hello and welcome to today's on-call webinar entitled Transforming Regions into High-Performing Health Systems. As you heard, I'm Stephen Samus, Vice President of Programs here at CFHI, and I'm pleased to be your host today. CFHI is a not-for-profit organization funded through an agreement with Health Canada, and we work shoulder to shoulder with healthcare leaders to support implementing and enhancing healthcare improvements across provinces, territories, and regions. We're pleased today to have more than 250 registrants for the session. As I introduce our guest speakers, I'd ask that you please take a moment to introduce yourselves in the chat box, who you are and where you're from. Joining us today for this webinar and to share the key findings and recommendations of his recent report, we have Dr. Yves Bergevin. Dr. Bergevin is a senior family physician, epidemiologist, and public health physician. He currently advises the Institut National d'Excellence en Santé en Services Sociaux in Quebec and national and international organizations. Also joining us are Helga Bryant, CEO of the Northern Regional Health Authority in Manitoba, and Paul Harris, Chief Executive Officer of the Southeast Local Health Integration Network in Ontario. We also have our producers Sheena Powell and Kelly Ripley operating behind the scenes here in Ottawa. So welcome to all of you. We're pleased to provide simultaneous interpretation for all on-call webinars. This may result in a few quick pauses in the dialogue today, not to worry. We invite you to participate in the chat box today in either official language. On today's call, we'll hear from our panel of health leaders about the past, present, and future of regionalization in Canada. We'll explore how integrated regionalized health systems could improve access to health services, and we'll look at how a way forward could help Canadian jurisdictions better achieve the triple aim of better health, better care, and better value. To get us started, I'd like to now hand it over to Dr. Bergevin.
Thank you very much, Stephen. It's a real pleasure to be with you today and to discuss with you how one might transform regions into high-performing health systems. First, I'd like to thank the team that participated, Keith Seilikson, Bettina Habib, Stephen Samus in particular from the Canadian Foundation for Healthcare Improvement, Jean Rochon, Cynthia Desmais, Ghislaine Boucher, Jean-Louis Denis, and Denis Roy. I think Denis Roy was really extremely helpful in guiding us through this process. And Stephen Samus and Maureen O'Neill provided tremendous support from the foundation, and Stephen was a key advisor on this study. The report is available on the CFHI website at the address given on the slide, so I won't go into much detail, but just try and provide some of the highlights today of the report. The purpose of the study was to provide insight and evidence on the impact that regionalization has had across Canada on the triple aim of better health, better care, and better value. And from that, to identify major findings and a way forward, including a vision for regionalization and areas for improvement in order to transform regions into high-performing health systems. Methods were quite straightforward. We did a scoping review of the literature. We interviewed 30 out of 32 senior health leaders from across Canada. These were deputy ministers, assistant deputy ministers, heads of regions, senior officials in Canadian organizations, and 2 former ministers. And then the research team met and discussed the findings periodically. The strengths of the study were due to the senior level of health leaders interviewed. Their answers were anonymous, so they would not be named, and therefore felt free to express themselves and express what is truly needed to improve the various health systems across Canada. And we found a very strong convergence of insights across Canada and from the literature. Unfortunately, we were unable to find any robust evaluations of regionalization across Canada, and the literature is primarily expert opinion, thus limiting the findings of the study. Canada continues to produce good health, with life expectancy having increased 3 years in the past 7 years to 81 years, and this is only 2 years behind Japan. However, as Stephen Lewis said, Canadian healthcare continues to be an underachiever. And testimony to this is some recent evidence from the Commonwealth Fund in 2014 comparing France and Canada and other countries, but we're highlighting the difference here in the area of out-of-pocket expenditure, getting same or next day appointment, after-hours care, and emergency department use. And we can see that Canada performs much less well in these 4 measures, which are important from a patient's perspective. I will not go through the details of this slide, but just to show that changes over time across 13 jurisdictions, the provinces and territories, have occurred haphazardly or on a political basis, and this has really not enabled us to have enough time with any jurisdiction to be able to observe the changes that were caused by regionalization. What were the major findings of the study? First of all, Canada is moving towards a 2-level governance system, the province or territory and that of the regional health authority, except perhaps Ontario, which is moving in that direction but still has several levels, the local level with hospital boards, what is becoming a regional level, but not quite, but we'll hear more from Paul Durand on this later, the local health integration networks, and finally the provincial government. We found that the optimal size of regions depends obviously on geography, which is very variable across Canada, but when there was sufficient population, a size of 350,000 to 500,000 appeared optimal, with road transport or air transport times of no more than 3-4 hours, both for patients but also for supervision, coaching, specialty services, etc. The major finding with regards to the triple aim is that things are better than before, but they're still extremely variable across Canada, and they're partial. We certainly have achieved some better health through an enhanced population health approach, better care with better response to community needs, to regrouping of services, to clinical governance and clinical networks, to regional service delivery plans, with enhanced organizational capacity and enhanced quality. Better value, again, better than before, but variable and partial. There's been much stronger evidence-based decision-making, better priority setting, better improved allocation and utilization of resources, improved cost effectiveness, including through lower unit costs of regroup services, and the avoiding of duplication and more rational care. Citizen engagement, well, it's been plus because there's been more engagement of municipal leaders and others, but the disappearance of local health boards has decreased citizen engagement at local level. The other key finding is that it's really been an incomplete results-driven program approach with unclear goals, targets, and a very weak monitoring system. Engagement of physician is improving, but it has been variable and weak. And patient-centered primary health care has been variable across Canada and weak relative to other countries. This, in fact, was a bit of a surprising finding given that we have excellent training in and education in family medicine. We've seen slow and variable progress in information systems and electronic health records, the frequent reorganization of the healthcare delivery architecture and regional structures that we've mentioned earlier, insufficient clarity in roles and responsibilities of governments, ministries of health, and regional health authorities, and inadequate financial coverage of essential drugs in ambulatory and home care settings, increasing the recourse to hospital use. Regions really are performing as integrators towards health improvement, providing better health, better care, and better value. And if one looks at a vision for regionalized high-performing health systems across Canada, we see the need to have strong executive leadership at the top here, professional physician leadership, and citizen leadership. This combination appears to be important to be able to achieve optimal performance. We think that we are proposing a vision which is realistic. The vision reflects recent developments in high-performing health systems around the world, including accountable care organizations such as Kaiser Permanente and Intermountain. And a very important finding is that if we were to combine the best characteristics of health regions across Canada, one would likely achieve such a vision. Such a vision is thus realistic in the near term for Canadian provinces and territories. We have identified in the way forward 7 areas for improvement, and these areas for improvement would incur modest one-time costs, but would incur also, more importantly, recurrent cost savings. And these are, first, to manage the integrated regional health system as a results-driven health program, transforming them into high-performing health systems, with clear goals, objectives, targets, baselines, benchmarks, and a strong monitoring system, as one would expect when one is managing a program of that size with a strong evidence base. 2, and not forgetting that most of the health improvements occur from outside the health services, we should need to strengthen wellness promotion, public health, and intersectoral action for health to better address the social determinants of health. 3, we should ensure timely access to personalized primary health care and family health and to proximity services, and I'll come back to that towards the end. But this is critical if we are to move forward. 4, we need to involve physicians in clinical governance and leadership, partner with them in accountability for results, and engage them in the required changes to physician contracting and remuneration. Certainly, fee-for-service does not appear to be optimal in all situations, and one would need to address this issue and consider mixed forms of remuneration for all the activities, whether it is clinical work, teaching, management, and research, and blended remuneration would appear to be the best, including some forms of capitation and others. 5, we need to engage citizens in shaping their own health destiny and their health system. 6, we need to strengthen health information systems, accelerate the deployment of electronic health records, and importantly, ensure the interoperability of electronic health records with health information health systems to move towards a real-time system. One patient, one record, clinical and financial. 7, we need to foster a culture of excellence, learning, innovation, and research, and encourage adaptive capacity towards continuous quality improvement. Finally, we need a very clear distribution of roles between provincial and regional levels with a strong accountability framework, the provincial government adapting a whole-of-government approach towards better health, dealing with health policy, financing, and oversight, provincial public health, and tertiary care with academic authorities, and the regional health authority being responsible for local primary health care, family health teams, secondary care, and coordinated and integrated care across a continuum, regional public health, and regional with municipal intersectoral action. Now, in order to move this agenda forward, which is a tall order, we think that focusing on Way Forward 3, the area of improvement 3, timely access to family health team and primary health care, is probably the one that would help transform the system. We're at a turning point from paradigm freeze, to quote the recent book, to what we think is a paradigm shift from hospital-centric episodic care towards evidence-informed, population-based primary and community care. And we suggest that Canada adopts goals and internationally comparable targets for December 2020, ensuring that over 90% of Canadians have access to a family health team or a community health center, and that too, we ensure coordinated and integrated care for 90% of high users, thus improving the quality of care and decreasing the recourse to emergency room or hospital use. Family health teams should ensure collaborative, continuous quality improvement, best evidence for the essential elements of modern family health teams, and a system of accreditation, but ensuring a pluralist approach to fit local needs, whether it's family health teams that are physician-run, community health centers, other models for addressing northern issues or issues of Aboriginal health. We need to have the management of change simultaneously at 3 levels of the system: federal in the context of the renewal of the health accord, provincial, and territorial. And in order to do so, we recommend time-bound working groups to reach these goals and targets. Members at those 3 levels, federal, provincial, territorial, and regional, composed of members of health executives, representatives of the College of Family Physicians, medical and nursing associations, academia, and patient representatives. And we think that if we were to do this and combine the best characteristics of health regions across Canada, one would move rapidly towards high-performing health systems and thus contribute to the triple aim of better health, better care, and better value for Canadians. Thank you very much. Merci beaucoup.
Thank you very much, Yves, for an excellent overview of the findings in the report, what we heard from the health leaders across the country, as well as the recommendations for the way forward toward the triple aim in Canada. I'd like to now turn it over to Helga Bryant. Please go ahead, Helga.
Good morning, everyone, and thank you, Steve and Yves. Thank you very much for your presentation. I've been asked to just spend a few moments and talk a little bit about the story of regionalization in Manitoba. And I'm going to start in doing that just by walking through a little bit the evolution of regionalization in Manitoba. We began on this journey in rural Manitoba. It began in 1997, and then urban, being Winnipeg and Brandon, followed immediately on the heels of that in 1998. We began actually with 13 regions. Winnipeg was actually 2. It was a community authority and a hospital authority. Very quickly, those amalgamated into one, becoming the Winnipeg Health Authority, which gave us 12, and that remained at 12 for some time, and then went down to 11, where 2 rural regions amalgamated into one. There was a desire at that time, I think, to amalgamate more than just those 2. However, as Yves has talked about, the political influence in that at the time changed quite quickly, and there was only the 2 regions that amalgamated. So then that then brought us down to 11, which we remained at for many years. And the goals at that time, and the goals by which the 11 regions functioned for all those years, really were around integrating services. Initially, Manitoba Health had provided home care services, guided long-term care services, provided public health, continuing care, and those moved over to the regional health authorities. So now the job was upon us to integrate acute care services and community services. And that was a very, very interesting time. The cultures were very different between those various programs, and that often created a bit of a push and a pull. Hospitals were very much at that point beginning to look at flow, reducing lengths of stay, increasing their utilization, which clashed somewhat with home care and the significant increase for the demands of home care and community services. By 2012, it was very clear in the province that we really needed to focus much more on system sustainability and system performance. Integration had occurred within regions. However, regions themselves operated very much in a silo structure, and given the increased citizen mobility throughout the province, the increased demands and expectations on the part of patients and the citizens, there was certainly a need for a change in that. So the imperative in May of 2012, when we amalgamated from 11 to 5 regions, was really to work, function, and really begin to feel as one system, even though we were 5 different RHAs. I believe as the 5 regions, we have worked fairly diligently at that. If one looks at the map of Manitoba, it quite resembles a hub and a spoke a bit, with the Winnipeg Health Region centric to the province, not geographically, but from population perspective. And then the other 4 rural regions are clustered around Winnipeg, with the Northern Health Region, the one of which I am the CEO, consuming 62% of Manitoba's geography, but with really less than 6% of the population. So it's very sparsely populated. Many of our communities are very small, some of them less than 100 people, and several of them with air access only, possibly a winter road in the winter, but some even then are only air access. 70% of our population are Indigenous, which of course then embodies that increased burden of illness and increased healthcare needs. In terms of what was gained, and I'm talking now about since 2012, certainly our focus provincially, and particularly for us in the Northern Health Region, has been around population health. We have worked very diligently on health promotion, illness prevention, and over the last year or two, it's been interesting how our conversation has shifted to that of looking at health equity, knowing that will mean that some areas will increase significantly more health services than others, because they start from a lesser service delivery place and platform. We're very much welcoming this focus, and both our communities and our providers really embrace this as a priority. The continuum of care, certainly we have all provincially funded programs and services included in our health region, or access to them. Many of those are tertiary services that are provided in Winnipeg alone, and we facilitate access to those services as well. Our challenges around the continuum of care relates to our jurisdictional challenges. We have many First Nations communities, which absolutely requires a very close working relationship with First Nations Inuit Health Branch and Health Canada, both on service delivery as well as some of their infrastructure and education needs. That is a real opportunity for us, and we very much welcome our really good relationship with First Nations and Inuit Health Branch, and find that to be very beneficial as we leverage resources and partner together. with clear understanding about what each of our different mandates, roles, and funding, both resources and challenges are. Increased focus since 2012, certainly around community engagement and the patient experience. Embedded in our acts are local health involvement groups, which are citizens of the community that have come forward and meet regularly to provide advice to the board of directors, who are also appointed by the Minister of Health and represent our public. The local health involvement groups are functioning in varied degrees across the region, but where they function well, they do really aid us in helping us understand the dynamics of various communities and being a communication conduit back and forth between the board, executive leadership, and the groups themselves representing their communities. We also are involved in deep engagement with patients, with communities, certainly with Indigenous peoples and communities. When one thinks that 70% of our population is First Nations, we strive diligently to develop very healthy, progressive relationships with chiefs and councils, with tribal councils, and with other First Nations agencies and organizations. I've talked a little bit already about First Nations Inuit Health Branch, and on health-related issues we partner very well and have contribution agreements wherein First Nations Inuit Health Branch actually support some of our programs and services. For example, they have some support in emergency rooms and some support in communities where we send a physician into those communities. We have some very innovative partnerships that we are very, very proud of, and I just want to focus on a few of those on the closing slide. I want to talk a little bit about Opaskwayak Health Authority and the Northern Health Region. We have a joint statement of intent. This was signed a little over a year ago by our board chair and the board chair of the Opaskwayak Health Authority. Opaskwayak Health Authority is on Opaskwayak Cree Nation, which is right across the river from the PAW, a significantly sized at about 4,000 people, and a very progressive, well-organized Cree Nation. They have their own health center on their First Nations land, and we are very privileged to be partnering with them. Included in the statement of intent is a schedule around primary care. We provide a physician and a nurse practitioner to them to practice in their clinic. That is done in a collaborative practice model. They use the EMR that the Northern Health Region uses, so that there is one health record between the First Nations community and the health authority. We practice advanced access with a focus on attachment and panel size on that community, as we do throughout our region. We're beginning to turn our minds somewhat to specialist services now, to provide increased itinerant specialist services, either from the region or probably primarily from Winnipeg, but that will also be provided in their clinic. And mental health services, we are partnering with them on mental health services. It is a theme throughout our region. Every community we go into speaks about mental health concerns, and we are partnering with them in that regard as well. Keewatin Tribal Council embodies about 10 of our First Nations community around the Thompson, Manitoba area. We're just in the early relationship building stages with that tribal council, and really right now our focus is on sharing of service inventory. They provide quite a few programs and services that we believe we can leverage, we can partner and assess where the gaps are and where the redundancies are, and try to create some better balance between our joint services. Cross Lake First Nation, you will have heard on the news undoubtedly that there has been a cluster of youth and young adult suicides in that community. I received an invitation from the chief of that community. It's a population of 8,000. It's a large community. Received an invitation from the chief to support them through this time. We were privileged and honored to do that and have sent a couple of staff in, as well as some psychology support and leadership support to aid them through this difficult time as a community. The outcomes of that invitation and our response to that really has been a deepening of our relationship with that community, increased trust and understanding of their issues, and we see that as a very strong foundation going forward, as we know that there will be some capital projects happening in that community, and there will be real synergy, I believe, between Cross Lake, the Regional Health Authority, and the provincial government as we partner together in that community. And First Nations Inuit Health Branch, we do have a contribution agreement with them. The amount of that agreement and the services and support included in that increases on an annual basis, and it is through that very good dialogue and relationship that we have with FNIB that we are able to leverage resources. And there, almost on a weekly basis, there's opportunity to explore more options in that regard. So in just a brief close, I would say that while the journey is slow, we are making our way slowly to better health, better care, and hopefully better value, although in a region that is so sparsely populated, geography that's bigger than France, with only a population of 78,000, the value aspect of this is sometimes quite difficult to measure and get a true assessment of. I thank you for your attention.
Helga, thank you so much. Really your final words there about a region that is larger than the size of France with the population that you have really helps to put things into perspective. And also thank you for outlining how the Health Authority is, addressing many of the themes and issues identified in the report, in fact, operationalizing those things, including the relationship building, integration, and care coordination for First Nations communities. Terrific. Thank you so much. I'd like to now turn it over to Paul.
Thanks very much. First of all, I'd like to thank the committee who prepared us for today, but I'd also like to thank Stephen for setting the context for this day, and for Eve and Helga for their presentations. What I'd like to do is talk about the LHIN perspective of regionalization. I'll give you a quick history and talk about some of the examples that are happening in the Southeast LHIN, and then talk about one example in a bit of detail, and then I'll talk about what's proposed for how the LHINs might evolve. First of all, if we move to second slide here, LHINs were created in 2005, and we're the last province to devolve to healthcare for the purpose of regional decision making. I do believe we're a devolved decision maker, and not quite the same as regional health authorities, but very much devolved with the responsibilities of changing the healthcare system. The Local Health Integration Act was actually passed in 2006, and there are 14 LHINs averaging almost 1 million people per LHIN. The Southeast LHIN has about 500,000 people, mostly rural, but the most rural of all southern LHINs. We include 84 health service providers, including 7 hospitals, representing about $1.1 billion. Of those 84 health providers, only 5 represent primary care, those being community health centers. So such organizations as family health teams, family health organizations, and solo practitioners are not accountable to the LHINs. We're governed by a 9-member board, which are order and council appointed, meaning they're appointed by cabinet, and all health service providers continue to have their own boards. This is the map of Ontario, which really shows how very different the geographies are among the LHINS, and the populations are almost as diverse. In our LHIN, the southeast, we have, again, 500,000, but it's important to note that these lines on the map were drawn by analysis by ICES, the Institute for Clinical and Evaluative Sciences. And in the southeast, for example, we know that 94% of the people that live within those lines receive health services from providers that exist in within those lines. So it's a measure of self-service, if you will, or self-care. If you look at the governance in the LHIN environment with all the health service providers continuing to exist, system governance is intended to emerge from collaborative governance. And what we mean by collaborative governance is boards working together. So there is all this additional social capital that's available, and the effort that we all undertake is to get those organizations working together to develop regional systems of integrated care. The mandates that the LHINS hold include local health system planning, include looking at the population growth, the age-specific population growth, the utilization history, the utilization projected in the future, what changes will happen to utilization techniques and approaches, what type of disease burden is carried within the LHINS, and then what type of capacity is required to meet that demand. We're also responsible for integration. Certainly, we still have a system that very much works as a bunch of independent organizations, and we're trying to, again, achieve regional systems of integrated care. Funding, again, in the southeast, about $1 billion for 84 health service providers, which deliver, and we hold accountability agreements with about 124 types of programs. The accountability agreements actually allow us to translate plans into action, because as we allocate money, $300 million to one hospital, as small as $100,000 to a small community agency, those allocations come with accountability agreements that are signed by the board and the CEOs of each of the organization with my board and myself, and that allows us to hold people accountable for the money and for what's required to be achieved from that money. We do have performance targets that are included in those agreements, and we monitor and publicly report on that. We also have the responsibility of community engagement, and that community engagement includes engaging the public, patients, stakeholders, providers, and professionals. The type of programs that we're undertaking in the southeast to improve and then change the system include a large hospital project, 7 hospitals, trying to have them work together to become a regional system of integrated hospital care. Addiction to mental health, these are examples of horizontal integration. Primary care reform, health links, which I'll talk about in more detail, and then a number of other activities and projects that we're undertaking to really increase the integration of services into a system of care. The expected improvements from this work is that we expect to see a health system that is integrated and functions as a system, one that responds to complex needs of our patients, one that provides access to high quality care and provides that care in an environment that is safe for the patient and the staff, one that provides this type of coordinated care within the financial means available. And this should also lead to improved access to higher quality care, lower wait times, fewer repeat visits, greater patient satisfaction, and greater staff satisfaction. The health links, which is an example, it was recognized that there's a number of people in our province who have very complex care issues. They have 4 or more chronic conditions, and they typically represent 1% of the population, but utilize about 50% of the funds that we spend in healthcare. And it's not that they are the problem using the money, it's that our system does not respond well to these people. And so in the Southeast, that represents about 5,000 people. We have 7 health links as shown here in this small map. I'll show you a bigger map in a second. And the key feature is that our health links are primary care led. And the intent of the health links is to develop coordinated care plans for each of these patients that includes in the goals, not just clinical goals, but the goals of the patients. So as an example, this is the map of the Southeast region and the 7 health link areas. And the one that's circled here represents the Quincy health links. And here is a provider map that ensures or shows that we have various types of primary care services, including family health teams, family health organizations, a nurse practitioner-led clinic, and the community health center, all working together. These have been independent organizations that had not worked together before, but they do work together now with regards to health links. And then all the other services represent the other sectors that are involved or could be involved in any one patient's care. And all those organizations, where needed for a particular patient, will be included in the coordinated care plan. I'm going to skip to slides, some other slides, and actually show you that what's happening as far as change is that we're seeing a reduction in repeat visits to emergency departments. We're seeing reductions in, I'm going to skip a number of slides here, sorry. We see a reduction in repeat admissions to hospitals, and we also see patient satisfaction going up. We see provider satisfaction going up, and length of stay decreasing, and urgent care visits decreasing. So really, in a very small amount of time, in a period of 2 years, we're seeing this type of change within our health links. So the effort that we've put into working collaboratively with these organizations has really helped to turn around the care for these particular patients. To move on to the evolution and the future of health links, or of local health integration networks, there has been a proposal that we're expecting will move to legislation, and we should hear about that shortly. But if this goes forward, there'd be 4 component parts, and I argue that there's really 5 component parts. One is that within each LHIN, there would be sub-LHIN areas identified that would really identify communities of care and would allow us to really focus our planning and service delivery and the change of services taking place at that lower level. And that would give us the opportunity to really create the vertical integration that will go along with the good work that's going on with regards to horizontal integration. Included in that proposal, if it goes forward, would be timely access to primary care, so bringing primary care into the LHIN environment totally. And then also actually moving home and community care into a direct service that LHINS would be delivering. In addition to that, there would be stronger working relationships with public health, which would help improve population health planning as part of our health system planning. And then the 5th piece of that would be clinical leadership, where we would see clinical leaders actually having a significant role within the LHIN at the sub-LHIN level, but also across the LHINs each. So that proposal was presented in December, and we're expecting to see legislation be introduced in this year, and hopefully sooner than later. So I'll conclude my presentation at this point.
Paul, thank you so much, both for helping us to improve our understanding of the role of the LHINs, and also, as you put here on the last slide, their further evolution in Ontario, which is very, very interesting. Really, particularly, though, looking at the programs and initiatives and the expected outcomes of the Southeast LHIN, and looking at how consistent that is with the recommendations of the report, And again, the very impressive results that you've been getting through your health links and how they are addressing some of the significant issues that have been identified in the report. So both presentations, I think, have really helped to highlight many of the key areas that were identified by the authors of the report, particularly the recommendations of the way forward. So we can see that through the regionalized structures, whether it be in Manitoba or in Ontario, in the case of this particular webinar, regions are working collaboratively to address the kinds of issues that were identified by those health leaders across the country. So it's great to see and speaks really, I think, in very promising ways about the future of healthcare in the country. We do have a couple of questions now that we encourage you to keep questions coming. We do have some time for a few questions, so if you have any questions for our speakers, please put them in the chat box. I will start with the first one, and that would be, this one really was for Helga from Nancy Merrow. Helga, do you have any outcome data to show as examples of the successes that you mentioned in your presentation?
You know, I saw that question, so I've had a little bit of time to think about it. Specifically with the Opaskwayak Health Authority, we've had that statement of intent in place just a little over a year. So the outcome data is not that readily accessible yet. However, we know from some pharmacy data that there has been a reduction in the prescriptions of T3s and temazepam. There was quite a lot of noted abuse of that or misuse of that, and the GP and the NP working together in a collaborative model together with the local pharmacists have really worked to reduce that. And from a system perspective, the attachment numbers are around 800 at OHA at this point and growing. So those are 800 patients that are now being able to access their services there versus the Northern Health Region Clinic in the PAW, which is just across the river. So those are two indicators that we are continuing to track.
Wonderful. Thank you, Helga. A question here for Paul. You did mention that about 1% of the Southeast population uses about 50% of the health resources. Cheryl is asking if you could please clarify that a little bit, sort of a little more clarity of who those, maybe what they're using and who that population is.
Yeah, across the province, we've recognized that about 1% are using around 50% of the resources, 5%, close to 75% of the resources is really quite significant. So it really creates the opportunity for us to improve the way we deliver care to those people. The problem is, as the question relates to, is identifying those people, identify the individuals. So we've gone through the development with clinical leaders of an algorithm that helps us really identify what are the key indicators, and that includes 4 chronic conditions, and then there are other aspects we can look at, repeat visits and repeat admissions. Repeat admissions actually are more telling than repeat visits to the emergency department. We've actually created an electronic tool with our family physicians called SHIP, Southeast Integrated Information Portal, and that is allowing us in almost real time to identify these patients, and it gives us, one doctor has told us that he has it on his screen all the time, and he was walking by in his office and noticed that one of his patients was in the emergency department, phoned up the patient and caught him in the waiting room and actually prevented a visit to the emergency department and had him come into the office right away. So this electronic tool has helped us incorporate the algorithm so that we're really able to identify and then constantly respond to these patients.
Thank you, Paul. We have 2 questions here, Paul, that are related, so I'll put them together. One from Jackie. Do you believe that responsibility for funding of primary care medical services will become a responsibility of the LHINS in the future? And the related question is, do you mean that the LHIN will take responsibility of planning for primary health care versus primary care?
So it's hard to predict what will actually happen if legislation will go forward, but the proposal that was presented would give more responsibility to the LHINs, and I'm certainly one that is advocating for us to have accountability for primary care, and it's about alignment. I think in all regional health authorities, it's not that each regional health authority goes off and totally independently does their own thing, that there needs to be alignment with provincial strategies. And that's what the accountability agreements really bring in Ontario, this alignment, so that right now we're charged with the role of integrating health services, but the largest touch point in the healthcare system, primary care, is not part of that. So we don't have all the tools, and I believe that we will have those tools.
Thank you, that's great. Another question here for you, which is related again, I think, to the future direction that you referred to. How you think developments of geographically based sub-LHINs will affect the system?
Again, it will allow us to really develop vertical integration. It's pretty hard to develop vertical integration in a community that might be a million people. So in the southeast, where our population is 500,000, we might have 5 sub-LHIN areas, and these will be tighter communities, and providers will know each other better, and it really will allow us to create the vertical integration. And my ultimate hope in all of this is that a family doctor in Brockville, Ontario, will be able to, through vertically integrating with addictions and mental health services, for example, which would be consistent across the region, an example of horizontal integration, that doctor in Brockville will be able to access addictions and mental health services for his or her patient the same way a doctor in Belleville would be able to, and that we really start bringing that consistency and that link and make life easier for family doctors, specialists, and other care providers in meeting the needs of their patients.
Thank you. That's excellent. It goes really to a question here that was directed for both Helga and Paul, which was around that whole issue of mental health and substance use. Helga, could you please talk a little bit about your reflection on the integration of that, of the integration of public health and what that's meant for mental health and substance use in Manitoba?
Oh, I mean, with public health and mental health both now being delivered by the Regional Health Authority, it allows us to really bring that whole concept of behavioral health and changing how people change their behaviors to seek more healthy kind of behaviors, which of course impact on mental health, on physical health, on emotional health. And I think with all of those program area responsibilities being housed under one governance entity, it allows for much better communication between those different program areas within a region, which then allows us to speak with one voice in a much better way with our communities, and aids their entry point into the system, because no matter who they come into first contact with, we try as a system to help them navigate then within, rather than us sending them back out and, go to this door or go to this door. We try to coordinate that from within. And I think that's been one of the larger benefits. And, Paul spoke about the multiple comorbidities and the complexities of patients. We see that in the North so fully all the time that we find that care is better coordinated because we are managing all of those various program areas.
Excellent, thank you. Helga, if I could ask you this question, since you have really in your presentation talked a lot about the evolution of the health authorities in Manitoba and including the reduction from originally 12 to 5. The question here from Cheryl is, one goal of regionalization was to reduce duplication and reduce administration. Was there evidence that the number of admin staff and costs for administration went down through that course of regionalization?
Well, I think when I look at the attendee list, I think there's some folks from Manitoba Health on the call. There were certainly expectations in that regard. When one thinks of 11 regions, each of them with a CEO, an executive team, and a board, and our boards are 15, there were 6 less CEOs, 6 less executive teams. There were many people that were either absorbed into the system into vacancies or did not have a place in the system, and which could be as high as 40 if one does the math. And certainly from a board perspective, and while they're not salaried, there are stipends and there's certainly travel. There were 90 less board members in the province when we moved from 11 to 5. So there certainly are less executive people in the region at that senior executive level.
Thank you. And I think the final couple of questions here for you, Paul. I mean, whenever change is coming, people are always very interested in that. Two related questions here. One is, if services are transferred from the CCACs to the LHINS, will the CCACs still exist? And the other one really is, when would you expect the decision will be coming for increased accountability for primary care in the LHINS?
So again, this is a proposal that would have to be translated into, most of it would have to be translated to legislation. So there isn't a commitment to do this yet. But if there is a commitment, so the question is regarding the CCAC, home and community care would move to the LHINS. So the proposal, the way it was identified, was that those people currently working in that environment would become part of the LHIN, and the board of the LHIN would be responsible for overseeing the CEO of the LHIN with regards to those services, in addition to what the LHIN currently does. With regards to primary care, I would see that would be not, say it happened, the primary care responsibilities came to the LHIN. In the first instance, it would be planning and performance, looking at monitoring performance. And so the actual accountability would be a next step after that.
Great, thank you. Well, I would like to take this opportunity to thank all three of you for great presentations today. Eve, thank you for your overview of the report. Really interesting and timely report on regionalization in the country, where we've come from and where we're going and the ways forward. And to Helga and Paul for really helping us to understand that we are already moving in this direction. We are acting on the kinds of recommendations that are in the report. Health systems are very cognizant of the kinds of issues that were identified, and it's great to see the movement that's happening. You see now on the screen a poll. Your feedback is invaluable to us for future webinar planning and design, so we ask you to please take a moment to provide us with some feedback on today's session using the live poll you now see on your screen. There are 5 questions we've asked you to just quickly address. We also invite you to sign up for our CFHI newsletter so that you can keep an eye on your email for a full listing of upcoming webinars. Once again, at this time, I'd like to thank all of our speakers for their great presentations today, and Kelly and Sheena for their work behind the scenes here in Ottawa to make the webinar happen. And most importantly, thank you to all of you for joining us today.